Hello, we're just chatting it up here before we start. We won't actually start till 9 o'clock, but we're glad y'all are with us. So we've got about,
1 minute.
what?
1 minute.
Got 1 minute. We've got about 2,000 of you that are going to be watching this, and you are really going to like it. I'm going to tell you why here in, 40 seconds?
So today's the first day of summer,
Yeah.
hot in Texas.
So it's so interesting for me to have this online teaching channel because for 20 years I had a teaching institute in Dallas, and I gave 10 two-day hands-on courses a year to dentists on every topic you can imagine. And so, but we'd have 50 to 100 people in a class. Now, with this online, there's hundreds of thousands that are subscribed to dentistrymasterclasses.com. And it's interesting answering the comments every day from all of you that are from all over the world. So thank you for subscribing. By subscribing, what is it, $39 a month? You allow us to keep going because this is not a undertaking without cost. You've got a videographer, you've got an editor, you've got a film studio, you've got cameras, you've got computers. It's involved. So by you subscribing to dentistrymasterclasses.com, it lets us keep the process going. So thank you for that. Okay, we're ready to go. Hello. Other than my video on how to double, triple, quadruple your practice by doing just the things you know how to do right now, with the comprehensive exam and consultation I teach you how to do, this is going to be the most instructional video you watch. The videos are in dentistrymasterclasses.com. What we're going to be talking about are fundamentals of myofascial and TMJ pain and dysfunction, diagnosis and treatment. Now that sounds a little boring, but this is what we're basically saying is, if you're a home builder and you don't know anything about foundations, you're hosed. This is the foundation. If you're a home builder, this is the foundation of everything we do. And when I hear dentists say, I don't treat myofascial pain or TMJ, interarticular problems, I go, what the hell do you do? That's like a home builder saying, now I don't do foundations, I just do kitchens or whatever you're doing. You have to know how to do this. You have to know about occlusion, the fundamentals of occlusion, which is a part of this. We're going to go over some of that this morning. But I find that dentists today know very little about occlusion, and most of them don't have any clue how to treat somebody with myofascial or intra-articular pain and dysfunction. I had a lady one time whose husband was the president of a university, and she was from a town several hours from here, and her jaw had locked following a dental procedure a dentist in Fort Worth had done, and he'd done a filling on a back upper left, I still remember this, an upper left second molar. And she said, after he did that filling, my jaws just locked. I couldn't open my mouth. And so I'm going to go through what I do with the exam. But my point is that one procedure threw her over the edge. I'm going to show you a video, an interview of a patient when I get to the end of this today that talks about how she'd been to all these TMJ specialists and had all these splints and everything else, and a dentist, she'd had TMJ problems, and a dentist did a crown on a lower left molar tooth, and the occlusion wasn't just right, and it threw her over the edge. So anyway, this seminar is going to be the second most important thing that I teach you. The most important, as far as your practice goes, is the one in the library of dentistrymasterclasses.com on how to double, triple, quadruple your dental practice with what you already know how to do, not teaching you any other techniques, because there's a million different techniques in the library of dentistrymasterclasses.com, but that one, how to double, triple, quadruple your practice with what you already know how to do, for you is probably the most significant one, but this is going to be the second most significant. This is the foundation of everything else we do. These are the usual presenting symptoms. Now, this is somebody that has either myofascial pain, that's muscle pain, or intra-articular problems, TMJ pain. The easiest way to explain this, and my folks here in the office are going to limit this to an hour and a half. What time is it right now? Okay, so I'll stop at 10:30. My wife says it's hard for me to say hello, goodbye in 30 minutes, but I'm going to stop at 10:30, and you're going to have more than enough information that you can do something with. So when somebody presents with myofascial pain or intra-articular problem, TMJ, what's the difference? Myofascial is muscle pain, and that's usually the start. If you can picture somebody with a leg shorter than the other, and this is a debate that's been going on forever, because people say, well, everybody with a bad bite doesn't have myofascial pain or TMJ problems. Why? Why does everybody with a bad bite, a malocclusion, not have either muscle pain or spasms or tightness or intra-articular problems? The same reason that everybody with a leg shorter than the other doesn't have leg muscle pain, back pain, knee problems, hip problems. Why? Remember this phrase, stress on an imbalanced system. If you've got a leg shorter than the other, but you go to work every day, I'm a visual learner. Can you straighten it up? I'm a visual learner, so if you picture this, and I'm sitting in a chair all day long, at the end of the day, I stand up, I walk to my car, I go home, sit down and have dinner, watch TV sitting in a chair, go to bed. Is that person that has the leg shorter than the other going to have muscle pain and spasms, knee pain, hip pain, back pain? Probably not. But what if that person with the leg shorter than the other jogs 3 miles a day? Are they going to have muscle, leg muscle, back muscle, hip, joint pain? Probably so. Why? Stress on an imbalanced system. Why do so many, I love orthodontists. We do Invisalign in our office on adults. Why do a lot of orthodontic patients have myofascial pain or intra-articular problems, TMJ, 3 or 4 years after orthodontics? They get the teeth straight, but the bite's off. If the bite's off and they've got a CRCO slide and they grind their teeth, they clench their teeth, there's a very good chance they're going to have myofascial pain and an intra-articular problem after about 3 or 4 years, after they've stressed the imbalanced system for that period of time. Now, what if they don't grind their teeth? What if they don't grind their teeth? There's no stress on the imbalanced system. Remember, the only thing that really counts as far as stress on the system is grinding of the teeth, clenching. The only time a person's teeth should ever touch is when they swallow. Go ahead and swallow. Feel your teeth touch. They shouldn't touch when you chew your food, and certainly shouldn't touch when you go through the day. That's why I give most of my patients a proper centrocrelation occlusion night guard with only the anterior teeth contacting to wear at night. it's like brakes on your car. You don't have to worry about grinding and clenching the teeth at night, bruxism. So anyway, it's stress on an imbalanced system, and these are the presenting symptoms: pain, tightness in the muscles of the face, because you're usually first going to have myofascial pain, muscle pain, master, medial pterygoid, temporalis, lateral pterygoid, limited mouth opening as it gets worse. And at first, it's just going to be spasm in the muscles. If I did my arms like this all night long, the next morning I'm going to go, oh man, that's tight. If they're clenching all the time, they're going to first have myofascial pain because the muscles are trying to protect the joint. Headaches, this is a common thing. A lot of sensitive teeth. Remember, abfraction and gingival recession is primarily caused from teeth clenching. See, the tooth, if this is the tooth, the root's held by the bone. The coronal part's out here, so it's not wild grinding. It's just clenching like that, and you're flexing it like you're breaking a wire. You know, if you do the wire like that long enough, you're going to break it. Well, the same thing happens with teeth. You get these abfractions in the side of the teeth, and you get gingival recession from teeth clenching, and also hypersensitive teeth. If somebody's teeth are all sensitive, say, all my teeth are sensitive to hot and cold, you know they clench their teeth. Pain in the TMJ may be to biting, popping, clicking, crepitus in the TMJs. So the way it goes, you first got muscle pain and tightness. Then you generally get a pop and a click. We're going to talk about that. Then you get to the point that you can't open your mouth. Now, you may not be able to open your mouth with just the myofascial pain. I'm going to talk about that in a minute too. In an hour and a half, I'm not going to be able to cover what I normally give a seminar on for 2 days, but I'm going to give you enough that you're going to know a lot more than you know right now. So this is when they say, where does it hurt? These are places, this is trigeminal neuralgia down here. We're going to talk a little bit about that, but these are the places they point. Either the disc or the lateral pterygoid or the retrodiscal tissue or the master muscle. They're going to point right there and say, oh, that's sore. That's usually a trigger point. Now this is a normally functioning disc. See, every joint has got a disc between the ball and the socket. And the disc is to keep the ball and the socket, the joint, from rubbing bone on bone. It's a pad. And so this is a normally positioned disc. This is the fossa, or the socket. This is the eminence. And so the disc is like a catcher's mitt, and the ball's in the catcher's mitt. And then as the person moves forward, the first few millimeters are rotation. Then it translates down the eminence, and the disc should stay between the ball and the bone the whole way, normal. A disc displacement with reduction. This is a pop and a click. So I take an MRI of every facial pain case that patient I treat, because then I know pretty much exactly what's going on with the disc. So the disc is forward. I'm going to show you some fascinating live videos of disc here in just a minute. The disc is forward, but when the patient opens, the ball pops back onto the disc as it goes down the eminence. So if somebody's got a pop and a click, what are you going to call that? An anteriorly displaced reducing disc. disc displacement with reduction. Remember, reduction means it goes back where it's supposed to go. Like if you've got a broken bone, a compound fracture, and you reduce the fracture, you're putting the bone back where it's supposed to go. Then finally, you have disc displacement without reduction, meaning the disc is forward, but when the patient opens, it's like a door jamb. It's like a snowplow plowing into a big bank of snow, and it can't move the snow. And so this is one of the times the patient can't open their mouth. Now this is another time when they have myofascial pain. If you've got, you grind your teeth all night long and you haven't damaged the retrodiscal tissue yet, but they can't open their mouth, then it may be from just muscle spasm or muscle tightness from doing this all night long. And the way you tell if it's just muscle, if you put some green stick compound between the teeth and manipulate into centric relation, that's why you got to be able to manipulate into centric relation. If you can't manipulate into centric relation, what are you going to do? So you then manipulate into centric relation and have them tap into that compound, and you'll see those muscles just relax. And you measure the opening from nose to chin, and if it's, say, 30 millimeters, and you tap a few times, the muscles are going to relax, and you're going to go from 30 to 35, or 15 to 20. The opening dimension is going to change. If it's an anteriorly displaced non-reducing disc, if the disc is the thing that's jamming it up so they can't open, then that measurement's not going to change. If it's 15, you tap them into the compound, and 15 minutes later it's still 15, then you know it's probably an anteriorly displaced non-reducing disc. But that's why I take an MRI of all these cases. I don't want to mess with having to figure it out. I've got what they're showing me in their mouth, and I've got the MRI. Now this is what you're looking at. This is my crude drawing of a mandible. This is the condyle. Here's the maxilla. Here's the teeth. Here's the disc. Here's the retrodiscal tissue. Here's the lateral pterygoid. So when you have a malocclusion, tell you what, I think I'll go through that in just a minute. So this is normal, anteriorly displaced, reducing, anteriorly displaced, non-reducing. Now believe it or not, these are the hardest to treat. The pops and the clicks are a lot harder to treat than if you use my system than a patient that can't open at all. Because if it pops and clicks, you can't put pressure on the disc. What we're trying to do is stretch out the retrodiscal tissue that's already torn and stretched, but the principle of this treatment is get the disc out of the way. I've gone through every type of TMJ treatment, over 40 plus years of practice. We went through, these guys in Alabama came up with a pull forward splint where you pull them forward, and when you pull them forward and you get the ball back on the condyle, on the disc, if they've got a pop and a click, and then they wanted you to work them back. And you slowly take the ramp off the splint and they go back. Well, there's a point that the ball, the condyle, comes off the disc and they're popping and clicking again, so you never get to the end. I went through the phase of disc plication. Well, remember, this retrodiscal tissue is like wet toilet paper. So if you try to pull an anteriorly displaced disc back and suture the disc to the retrodiscal tissue, it's just a matter of time until whatever you sutured it with pulls through and now you got to pop and a click again. When I was first in practice, I had 2 patients have plication surgery by a well-renowned oral surgeon, well-intended, and within 2 or 3 months, it was just back like it was. I went through the phase where we put a screw in the distal part of the condyle and lassoed that disc to the screw. Well, the problem is, over time, that whatever you lasso it with is going to come loose because the disc is not going to grow back to the retrodiscal tissue. So the only thing holding it in place is that suture. So it doesn't work. And suturing a disc is not easy. I was in a surgery fellowship for 2 years, and that's a really tight space. And if the whole thing is torn loose, getting through the internal part of the disc is very difficult. So this is the takeaway. You cannot reposition the disc. You cannot reposition the disc. And I sat up in the middle of the night, one night, about 25 or so years ago, and I said to my wife, you can't reposition the disc. What do you have to do? We want to get rid of the disc. We want the disc to get out of the way. That sounds dramatic, but I'm going to show you how to do it and why you do it in a minute. You can't reposition it, so what are our objectives of treatment with a TMJ patient or a myofascial pain patient? What are we trying to do? What's the goal? We want the patient to be comfortable and functional 99% of the time. Comfortable, no pain. Functional, they can eat a hamburger. They can open their mouth and eat a hamburger. So what is that? I'm a visual learner, and I think you'll like this. If you can give me an example of something, it's like a golf swing. If you can tell me it's like this, that's better for me than saying keep your elbow in and do all this. If you can picture a dog, here's a clothesline, and here's a dog. Here's a dog, and he's on a leash connected to the clothesline. And here's the yard.
Can't see who's on the
Here's the yard. Now remember, the disc doesn't have any nerves. The nerves are in the retrodiscal tissue. So the thing that hurts is when you stretch that retrodiscal tissue. So if this dog is on a leash connected to a chain and a cat runs across the yard and that dog takes out running and he hits the end of that leash, he's going to jerk back like that and he's going to have pain. Now what if the owner though gets a longer leash or a stretchy leash, a longer leash and a stretchy leash, so that dog can cover all parts of the yard. No matter where that cat runs, that dog doesn't hit the end of that leash until, anywhere in the yard. That's comfortable. This dawned on me. What are we trying to do? We're trying to reposition disc. We're trying to do all this baloney stuff. And you cannot reposition a disc. You can't suture it back there. So we want to get rid of it. Now you could just cut the retrodiscal tissue. You could just cut it. Now why do you not want to do that? Number one, it's a big surgery. But number two, if you don't cut it and the condyle comes forward, and is functioning on the retrodiscal tissue like a disc, it can, according to the studies, form a pseudodisc. So the bottom line is you don't need to do it. You don't have to have a disc. I've reconstructed many a case that has no disc. They've just ground, whatever the teeth look like, if the teeth are wound down, you know the condyle is going to look the same way. It's going to be ground down. So they have no disc. And as long as they don't have a centric relation to centric occlusion slide when they close their teeth together, it's not an issue. My brother and I have taken these survival courses where you go out for 7 days with nothing, and you have to make, procure your food and make fire by rubbing sticks together. Well, can you create friction, sticks rubbing together, if you're just pushing stick to stick? No. You've got to rub it. So if you don't rub the condyle in the condylar head in the fossa, there's no friction. There's no pain. If you've got a stable occlusion with no centric relation to centric occlusion slide, so if the patient should just squeeze their teeth together, there's no rubbing, there's no slide, you're not going to have pain. And I've had stable cases for 30 plus years that have a proper occlusion, reconstructed their whole mouth, and have no disc. Okay, so this is a normal condyle on a cadaver, and the disc looks like a bow tie, with this being the knot, this being the front and the back of the tie. So when it moves forward, it's moving along the eminence. Remember, the first few millimeters are rotation, then it translates down the eminence. Now this is a normal disc. Here's the condylar head, here's the fossa, here's the knot in the bow tie, and here's the distal, and here's the mesial of the disc. And so as this condylar head rotates and then translates down the eminence, then in a perfect world, the disc goes with it and stays between this bone and this bone as a pad. This is an anteriorly displaced disc. Now we don't know if it's reducing or not. See, the disc is forward of the condylar head. Here's the fossa, here's the eminence. Now what's made it come to that point? Normally it's stress on an imbalanced system. It could be whiplash, that the head came back and the jaw came open, but normally it's that micro trauma of a clincher on an imbalanced system, a bad bite, a malocclusion. Again, that could come from a crown, they could be born that way, it could come from orthodontics. Nobody's a bad person, it's just nobody really understands occlusion. When I'm upset with 2 orthodontists in Waco, because when I was first in practice, I would have patients come. I trained in occlusion at the Pankey Institute before I started my center in Dallas, and I had some fabulous people training me in occlusion. Guy Haddix, Bill Bryant, Pete Dawson, Parker Mahan, Alvin Filastri. That was the foundation of that institute. So I knew I am not a know-it-all. I don't have all the answers, but I know occlusion. Just because I've had so many good mentors and had so much experience. So these cases would come back to me from orthodontics, and they'd have 3 to 4 millimeters CRCO slides, meaning when you manipulate the condyle into the fossa and touch the first tooth contact and then have the patient squeeze, they'd slide 3 or 4 millimeters, and the condyle is connected to the tooth, so when the teeth are sliding on each other that far, the condyle's doing the same thing. And I said, I can't live like this. So I contacted all the orthodontists in Waco and all the oral surgeons. I said, I don't want to be the know-it-all, but I know occlusion, and we can't keep living like this, because I don't want the patient coming back to me not knowing they've got a malocclusion, and then if they're a clincher, remember it's stress on an imbalanced system. That's why the argument has always been, well, it's not occlusion because some people with a bad occlusion don't have myofascial pain or intra-articular problems. Why? They're not stressing the system. They're not running on the leg that's shorter than the other. It's so simple. And so I said, I'd like to meet with whoever wants to meet on a Friday afternoon once a month and go over this. And so I had 2 orthodontists and 1 oral surgeon. Charles Withers, Bob Nallen were the orthodontists, and Dave Grogan, who became the chairman of the oral surgery department at Baylor College of Dentistry, was the oral surgeon. And we met every one afternoon, once a month, and went through occlusion. So I knew when I sent those people patients, they were going to get to the end of treatment and pick up a handpiece and fine-tune the occlusion. They knew how to manipulate discentric relation. They knew how to, to equilibrate the patient. They knew about balancing side interferences, working side, CRCO slide, where the teeth were supposed to hit. And either they'd do it, I didn't want to do it, but if they didn't want to do it and they said it's just for whatever reason, they could send it to me. But the main thing was the patient was not clueless. The patient was not clueless. Think about this like it's your daughter or son and they had orthodontics or whatever. You don't want to take a chance on them developing a TMJ problem. These are serious problems. So anyway, those 2 guys are retired. I'm still upset with them. And now I'm kind of having to go through the whole thing again because I find that people coming out of school today and most people that are in practice don't really understand occlusion, myofascial pain, and intra-articular pain and dysfunction in treatment. Okay, so this is a proper disc here, position. Here's another one. This is an anteriorly displaced. Here's the condyle. Here's the fossa. Here's the disc. When the patient moves forward, this one's an anteriorly displaced reducing because it pops up here on the top of the condyle again. This is an anteriorly displaced non-reducing disc. See, here's the condyle, here's the disc, here's the fossa. And so when they open, see the disc is right here. So they're going to have limited opening. It's like a door jamb. Normal TMJ anatomy again. Here's the condyle, there's the knot, here's the bow tie, there's the disc. There it is again. This is normal, condyle, fossa, disc, there's a knot, there's the bow tie. This is translating. See how the disc stays between the 2 bones. Anteriorly displaced, reducing or non-reducing, we don't know because the condyle's in the fossa. Now if you use it, I'm going to show you a cine here in a minute. Now this is a normal disc. Here's the condyle, here's the fossa, here's the eminence. Okay. See, here's the disc. Frank Dalwick was the head of the Parker Mahan Center for Facial Pain in Florida, and he gave a seminar at my teaching center in Dallas, and he was kind enough to give me these videos. So these are on cadavers. A live patient didn't have to do this, but you can see how the disc stays between the condyle and the fossa. So that's a normal. All right. This is an anteriorly displaced reducing disc. See how the condyle pops back onto and off of the disc. Now when you have this, You don't have to have an MRI to know what that is. What is, that's a pop and a click. If they have a pop and a click, listen to what I'm saying. Those are anteriorly displaced reducing disc. These are the hardest to treat because you can't sustain pressure on the disc to pull it forward and stretch or tear the retrodiscal tissue, because we want to get rid of that disc. Okay, now this is an anteriorly displaced non-reducing disc. See how flat that is? This person's teeth look just like that. Now here's the disc, and it's just jammed up in the front. It's like a snowplow driving into a snowbank. It can't move past a point. Think of the dog on the leash. The retrodiscal tissue is the leash. This is what that person's teeth look like. And so when they look like that, you can bet your boots the condyle looks just like that. Now what if they can open wide? That means they've done their own tearing and stretching of the retrodiscal tissue, or just destroyed the disc, so it's not a dog on a tight leash anymore. What are the objectives of treatment? Comfort and function 99% of the time, meaning can you eat a hamburger? Can you open your mouth? Can you run all around the yard without pain? So they've done it to themselves. So what about occlusion? This is unstable if only the back teeth contact in centric relation when the condyle's seated, because this is a fulcrum. This is like a seesaw. They're going to pivot on that back tooth. Is this necessarily going to cause myofascial pain or an intra-articular problem? You're smart enough. Is it? You on the first row.
Unless it's under stress.
When would they have pain?
If the system's imbalanced under stress.
If a system is under stress. In an unbalanced system under stress, the leg, the condyle, they've got to clench their teeth. If they're not a teeth clencher. Now what if you had a bad bite and you had a proper occlusal orthotic appliance or centric relation appliance that you wore at night when you're sleeping? Do you have to equilibrate the bite? No. If you've got a disciplined patient, I've got a veterinarian whose teeth are so far out of whack, you'd have to do root canals on the teeth. So she wears a occlusal orthotic appliance at night, which gives her a perfect bite, and you have to tell them when you take this off, you're going to think I've changed your bite, because your bite's going to feel so funky because you're going back to your real bite. It's not changing your teeth. And then during the day, have the patient hum without making the sound if there are a lot of people, because that puts the lips together and the teeth apart. Remember what I'm telling you. The only time teeth should touch is when the patient swallows. Go ahead and swallow and you'll remember it. They shouldn't touch when you eat food. They shouldn't touch as you go through the day. So have them, everybody should do that anyway. Just, but don't make the sound or they'll think you're crazy. So that's unstable. This is not stable because the teeth are in centric occlusion, but they've got a slide. So remember, the teeth are connected to the condylar head. So when the teeth slide into centric occlusion, the condyle comes with it. It's out of the socket. So if they're clenching, they're going to tear and stretch that retrodiscal tissue. This is unstable if they've got a premature contact on anterior teeth. Some of the worst TMJ cases I've seen are people that some dentist did a bridge on the front, and maybe they tested them laying back in the chair, but when you're in the alert feeding position, when you sit up, your mandible comes forward about 1/2 millimeter, and so if you don't check it in the alert feeding position, then the bridge or the anterior teeth are distalizing that condyle onto what? The retrodiscal tissue. Where are the nerves? In the retrodiscal tissue. So you're killing them with that bridge. So this is unstable. Now this is stable. If you're only hitting on these teeth right here and the condyle was in centric relation, meaning it's maximally seated in the fossa. Don't get caught up in uppermost, midmost, any of that kind of stuff. When you hinge into the socket and you can hinge that centric relation, the only position you can hinge the mandible in is centric relation. You can't hinge it if it's muscle braced. If it's bone braced, you can hinge it. So you don't want somebody to run around like this, but this is how I make my occlusal orthotic appliances, because they only wear them at night, and it takes teeth 24 to 48 hours even to begin super erupting or moving. So if only the anterior teeth contact the cuspids on that occlusal orthotic appliance, 90% of the muscle fibers of closure shut down and don't fire. Because if the back teeth are contacting, the brain says, oh, we're grinding food. All the muscles need to fire. If only the anterior teeth are contacting, then the brain says, oh, this is Danny. We're just incising. The anterior teeth contacts are like racehorses. The back teeth contacting are like plow horses. So the brain says, we're just incising. We don't need but 10% of the muscles. So you're shutting down 90% of the muscles of mastication if only the cuspid teeth touch on your occlusal orthotic appliance. Guy Haddix was this crusty old guy from one of the Carolinas that changed my life back when I was on the visiting faculty at the Pankey Institute. Because Guy and I were walking along the beach outside Key Biscayne one afternoon after a class. He and I had been teaching it together, and I thought I really knew occlusion. He said, do you get your facial pain in TMJ patients over the problem? I said, a little bit here and there. He said, you want to know why? I said, yes. He said, if you're making the splints like we teach them out here, they're in hyperocclusion on the second and first molars. I said, tell me about that. He said, because when we make the splints, we have all the teeth contact on the splint, right? I said, yeah. He said, if you do that, and you can't pull shim stock out all the way around, you're going to have hyperocclusion on the second and first molars. Now, I love the Pankey Institute, but this was anecdotal. And Guy said, go home and make a splint and have all the teeth contacting, then take the posterior teeth out of contact, the molars, with an acrylic burr. And he said, then have them tap again. And he said, you're going to have contacts again. He said, then take the posterior teeth out of contact again on the splint. Have them tap into articulating paper again. You're still going to be contact. He said, you're probably going to have to do it 5 times until you don't get contacts on those posterior teeth. And that was the beginning of me really learning how to treat TMJ and myofascial pain. So thank you, Guy, because he said, you know, he got out of the box. He said, these won't work because you're fulcruming on those back teeth. They're seesawing on those molar teeth. So this is very stable with an occlusal orthotic appliance. You can't leave the teeth like this forever because they'd super erupt. So this is ideal occlusion. Bone braced condyles in the fossa. That's called centric relation. Maximum intercuspation of the teeth, meaning every teeth doesn't hit, but you've got, when they're close together, it's solid bite. Centric occlusion. This is centric relation. This is centric occlusion. The side movements, the eccentric movements, are on the anterior teeth, cuspid to cuspid, extending possibly to the bicuspids on the working side if group function is desired. I hate a bunch of writing on a slide, but when you refer back to this, you're going to remember what it is. Meaning, when you go side to side, you want the contact as far forward as possible, because here's the big muscles back here. It's like a nutcracker. If you're hitting on the posterior teeth, when you grind the teeth side to side, you're going to put more pressure on the system. and you're going to break teeth. So when you go side to side, you want those side to side movements as far forward as possible. You don't want them on the first or second molars unless the patient has an anterior open bite and only hits on those teeth, and that's a whole nother system we're not going to go through today. If the cuspids are broken down, you may extend the working side movement to the bicuspids. You don't want any balancing side contacts. I mean, if you move the jaw to the right side, the mandible to the right side, you don't want any teeth on the left side hitting. This is not an occlusion seminar. I did that a couple weeks ago. No contacts between the incisors, slightly lighter than the contacts between the cuspids and molars. No contact on posterior teeth before cuspids and CRO, meaning when the patient bites down and squeezes hard, you put shim stock between the four anterior teeth and you can pull it through. You put shim stock between the second molars and the distal of the first molars and have the patient squeeze as hard as they can, and you can pull it through. What if you can't? You adjust the contact so that they're not contacting on those teeth. Remember, if you're contacting on the four anterior teeth, you're going to distalize the condylar head into the retrodiscal tissue, and it's going to hurt like hell. If you're contacting on the second molar or the distal of the first molar and you can't pull shim stock through, then it's going to be a premature contact, even though it's marking the same as the other teeth, because the muscles are right on top of those teeth and they contact tighter than the anterior teeth. So you've got to be able to pull shim stock, at least shim stock, maybe articulating paper between the second molar, the distal of the first molar, and the four anterior teeth when the patient squeezes hard. All right, closure interference. This is a premature contact causing forward displacement. Now remember, I'm trying to give you the fundamentals in this short webinar. The condylar head is connected to the teeth, so if this tooth is sliding forward, the condyle is sliding forward in the fossa. When does that make a difference? You on the first row.
When a system is under stress.
When it's under stress and it's imbalanced. So if it wasn't under stress, who gives a rat's ass? It doesn't matter. If they're just hanging their jaw all day long and not stressing the system, it's like not running on legs shorter than the other. So this would be like this. See, this is centric relation, a maximally seated condyle, but they've got this tiny little interference right here. And so when they squeeze and this bad boy comes forward, it pulls the condyle out of the fossa. It's going to stretch and tear that retrodiscal tissue, and what's going to happen? You again on the first row.
That pain, because the
What was your
nerves are-
name again? You're really a smart student. They're going to have pain. You're stretching that bad boy. And if you're clenching, but it only counts if you're clenching. Okay, so this is a contact back here, and you're fulcruming on this. So that's not, see, so it's going to pull the condyle forward when you slide on that. So centric relation, remember, when you say the word centric relation, that only has to do with the condyle maximally seated in the fossa, irregardless of what the occlusion is like. It's when you manipulate the condyle into the fossa. And so even if they had a premature contact here, we're not talking about the occlusion. Centric occlusion is how the teeth hit, irregardless of where the condyle is. When you bite down, what's the bite like? That's centric occlusion. Even if you don't have the fossa, the condyle in the fossa. So this would be a perfect restoration if you just took this grinder and just ground the occlusal of the posterior teeth off so that you're only contacting on the cuspid teeth, because what does that do? It keeps the patient, unless they had premature anterior contact on these 4 teeth, it keeps them from having a slide on the posterior teeth. Now, please don't do this in the mouth unless you're restoring all the teeth of the posterior teeth, but you're taking the posterior teeth out of it. And that's where you have the CR, centric relation to centric occlusion, slide on the posterior teeth. So if you took the occlusion completely out, manipulated into centric, the vertical dimension was right, and the 4 anterior teeth did not contact prematurely. You could pull shim stock or articulating paper between them. This is a perfect seating of the condyle because the posterior tooth is not preventing the condyle from seating maximally. Do you agree with that, ma'am?
Yes.
Okay. Can you explain it any better than that?
No.
Okay. So she says, that hurts right there. Well, what is that? That's the master muscle. It may even be retrodiscal tissue. So only when posterior disclusion is obtained by an appropriate anterior guidance can the elevating activity of the temporal master muscles be reduced. Meaning, when the posterior teeth are not contacting or not sliding, that's the only time that the master muscles and the temporalis and the medial pterygoid muscles can relax if there's no contact on those muscles. Otherwise, see, if you just have a patient do this, have them relax their jaws. This is a fun exercise with patients. Relax their jaws and try to contract the master muscle of the temporalis. Go ahead and try it right now. Try to contract them with your teeth apart. Can't do it. Now put the teeth together and squeeze. Feel them contract? So only when the teeth aren't contacting, the posterior teeth, will those muscles relax. That's how I developed this occlusal orthotic appliance with only the cuspid teeth contacting. Because I hope you get the idea with this short webinar that the posterior teeth are not preventing the condyle from seating maximally in the fossa. Does that make sense?
Yes.
Okay. So this is perfect. See, I prepped all the lower posterior teeth and I'm contacting on the cuspids in centric relation because I'm restoring those posterior teeth. You get it? All the teeth are out of occlusion and I'm contacting on the cuspids. I'm taking an occlusal restoration record here. Just like this bad boy, when I cut those teeth off, the posterior teeth, then I put bisacrylate on top of it and manipulated. I actually did it on this volunteer. I cut the teeth out of occlusion and then put that bisacrylate on top of it. And then, see, I'm manipulating into centric relation, maximally seated condyle, and then I squeezed it together. You get it? And then I trimmed it. So that's only the cuspids are contacting before I put the bisacrylate on the teeth. And stop me if something I'm saying doesn't make sense, Sharon. Okay, so then this is how you know you've got it right on the money. See, there's the contacts, and I grind the rest of it off and leave those dots. The cuspids are contacting, then these are contacting. Now, what else am I going to do in the mouth? Now, this is a perfect bite, but even at this, once I get it just right, I'm going to take the second molar and the distal of the first molar slightly out of occlusion. Occlusion. You get a prize. Okay. See, so here we go. I did these teeth first, and there's no CRCO slide, so now I've prepped the lower and the upper molar teeth. And then when I put the restorations on, I'm going to put one side on at a time, and I'm going to have them tap lightly into articulating paper, because I don't want these posterior teeth, I want the contacts to be in here. I don't want these 4 teeth or the distal of the first molar or the second molars to be contacting. I want them to be slightly out of occlusion. Then I want the anterior guidance to be on the anterior teeth. Bill Bryant told me something. Are you keeping up with the time? Are we doing?
It's 5 till 10.
Okay, so we're doing pretty good. We got 40 minutes. Bill Bryant was a dentist in Dallas, and he and I were teaching a course at the Pankey Institute, and I thought I was second to nobody in understanding occlusion. I thought, I understand occlusion. And so Bill, then, I was giving a seminar on occlusion, and Bill said at me, said, now here's an interesting question for you. If you had,
That's Bill Bryant.
yeah, he wrote this book, Occlusion 101, which is everything you want to know about occlusion. I've got only a couple of copies of it, which I guard with my life. But he said, what if you only had a person with no teeth, but they had an upper first molar only? Everything else was gums. Because I'd always thought anterior guidance on anterior teeth, like this. And he said, where would your anterior guidance be? And I thought, whoa. And I thought about it, and I thought, anterior guidance is whatever's in contact when you move side to side, move the mandible side to side. And so that molar on the lower gums is the anterior guidance. So it was one of those Guy Haddix moments. It was a Bill Bryant moment. He made me think anterior guidance is the teeth contacting when you move the jaw in any direction. What tooth is contacting? That's the anterior guidance at that point. In a perfect world, you'd like the anterior guidance to be on the anterior teeth. Why? Anybody in the audience know the answer to that question?
Sorry, I was looking at Bill Bryant's book.
Were you paying attention?
No.
All right. Why do you want the anterior guidance only on the anterior teeth versus the posterior teeth?
Because the posterior teeth have the pain and the strength to
The muscles is what you're trying to say.
engage
Yeah.
muscle.
The muscles are more serious. So if you're on the back teeth,
Because if they're only on the front teeth,
you're putting so much more pressure on the system,
Put
because
your
when you're
finger back
back here, yeah, take your finger and put it between those teeth and bite down, and bite down between your front teeth. Which one would you rather have bite? You don't want the bad boys hitting, because the muscles just put so much stress on the system. So that's why you want the side movements on the as far forward as you can get it, so you don't break teeth and you don't contract all those muscles. Remember what I'm telling you right now. 90% of the muscles of fibers of mastication don't fire if only the anterior teeth are contacting. So when you go left, right, and forward into protrusive, there's no reason to have those teeth contacting. Same thing with an occlusal orthotic appliance. Do not put all the teeth contacting on an occlusal orthotic appliance. Only have the cuspids contacting. Why? Muscle fibers. Duh. So see, this is my occlusal orthotic appliance. Only the cuspid teeth are contacting. Our objective is to make centric relation and centric occlusion the same. Centric relation occlusion. That means, and you don't have to be perfect with this, just when you bite down and you put the condyle maximally seated in the fossa, you want the teeth to contact between the cuspid and the mesial of the first molar simultaneously on both sides. Now, all of those teeth don't have to contact. All of them don't have to contact. It's like what do they call it, the occlusal table. It's like a table in a restaurant. If you've got 20 legs on that table, all 20 of them don't have to contact. You just don't want one or two contacting so that it's teeter-tottering. You want enough contacting so no matter where you push on that table, it doesn't rock. That's the same thing with the bite. You may only hit here and here, but you're hitting here and here on the other side, so when you touch together, there's no slide. And then you get rid of the balancing side contacts. You don't want the working side contacts on the molar teeth, and you'd like to have protrusive contacts on the anterior teeth if possible because of what? Muscle fibers. You want to put as less stress on the system as possible, so you want to make centric relation and centric occlusion the same. The teeth to contact on both sides at the same time in the cuspid, the mesial, or first molar region when the condyles are maximally seated. Duh. Centric relation to occlusion is sagittal plane. Here we go. Boom and boom with no slide, no serosseal slide. If you totally don't know how to occlude teeth, but you just understand it. I can't stand it anymore. Watching these patients come in with this crap occlusion. If you just make the patient contact on both sides at the same time and learn how to manipulate into centric relation. Watch my video on how to manipulate into centric relation, and then touch the teeth together and get the slides out. Even if you don't do it perfectly, the patient is going to be so much better just getting rid of the slides. I saw a lady from Weatherford last week, and she's just pounding it. She'd had TMJ problem, myofascial pain for 30 years, and she's just pounding those second molars and first molars. So I just took them out of occlusion, in as orderly as I can. But basically, you could have just cut them out of occlusion, and she's 100 times better just after doing that. She said, oh my gosh, why hadn't anybody done that before? So what was I doing? I want the teeth to contact simultaneously on both sides somewhere between the cuspid and the mesial of the first molar with no slide, with the condyle seated. Let me say that one more time. I want the teeth to contact simultaneously on both sides between the cuspid and the mesial of the first molar. Every one of those teeth don't have to contact, but you don't want the contacts on inclined planes. You want them a dot on a flat surface with the condyle seated, and when they squeeze, no slide. That's the only time occlusion makes any difference, is when you squeeze. So that's when you want to check it, and then you want to check them in the alert feeding position. That's when you sit up like this. That's it, and have them squeeze. I hate this slide. It's too much stuff, but you can reread it when you've got time to read it. The patient will be able to open, this is the objective, they'll be able to open their mouth comfortably, at least 45 millimeters incisal edge to incisal edge of the central incisor teeth. How did I come up with 45 millimeters? You can eat a hamburger. Dog on the leash in the yard. The dog can run all over the yard on the leash, chasing that cat without getting jerked back. 45 millimeters is enough to eat anything. The patient will be able to chew, speak, laugh, and sing comfortably. The muscles of the face and the TMJs will be comfortable. The teeth themselves, i.e. their condition, are another consideration. You got to see where the teeth are. But when they can do this, what have you done to make them be able to do this? What's not stretched out and hurting?
Muscle.
Retrodiscal tissue. Is that what you're trying to say? Yeah, because that's where the nerves are. So it's not dog hitting the thing. If you get rid of that damn disc, get it forward, stretch it out. You could cut it surgically, but you really don't want to do that because it's a surgical procedure, and you can stretch it with the technique I'm showing. Wait, let's go back. Got some more. Popping, clicking, and crepitus in the TMJs may continue, especially popping and clicking. Crepitus just means bone on bone, kind of sounds grinding. That's just life. But if you don't have a CRCO slide, you're not rubbing. If it's just solid, now pop and click is harder because it's harder to get pressure on that disc when you're doing what I'm going to show you how to do in a minute.
We need to move to that because it's about 10 o'clock.
Normally the popping and clicking goes away after several weeks or months because the retrodiscal tissue stretches out anteriorly and the anteriorly displaced disc moves forward and stops reducing. Crepitus will continue, but is not a problem. Never say you're going to get rid of popping. It usually does go away. Okay, start. Let's see, is that, you're going to do that one, Casey? This is an MRI. Here's the disc. See, that's a normal disc. It stays between the ball and the socket the whole way. Okay, next. All right. Now, this is an anteriorly displaced reducing disc. Here's the disc. There's the condyle. Here's the fossa. Okay. See, it's off the disc. Now it pops, it's on the disc, then it pops off. Okay, now this is an anteriorly displaced, non-reducing disc. This is the disc right here. This is a door jamb. And so over time, if they keep doing what I'm showing them, that will get out of the way. So this is not an MRI seminar. I've got an MRI seminar I give. That's not this. It's just to give you an idea. So this is the anteriorly displaced non-reducing disc. See, it's right here in front of the condylar head. Okay, we're going to pass on this. That's putting me to sleep, huh?
You can just go next.
What?
You can just click next.
Yeah. Okay, so equilibration. See, this is a balancing side contact right here. So I've got rid of this so they don't contact on the right teeth when the manual moves to the left. There's no contact on the balancing side. So this is that balancing side contact again, and I removed it. So one little thing like that can do it. All right, the occlusal orthotic appliance, like I said, I've got a video on how to make those. We're going to skip it in the interest of time. So this is the appliance, and the only teeth that are going to contact are the cuspid teeth. So all the eccentric movements are on those cuspid teeth. Why? You on the first row. Why only on the cuspid teeth? Why not the back teeth?
Because the muscle fibers.
The muscles don't contract. 90% of the muscle fibers don't fire if only the anterior teeth are contacting. So why don't you put the contacts just on the lower incisor teeth, because they're the little baby teeth. They're small roots. They're fragile. The cuspid is a big boy. It can take it. So put it on the cuspids because it's anterior enough, and it allows you to. Okay, so what I'm doing with this treatment is I give them these. This was a stroke of genius when I figured this out. I said I need something they can measure. So I measure 45 millimeters of tongue depressors. If you measure this, it's 45 millimeters. So what the beauty of this is, they start with however many they can put between their front teeth. See, she can go to 50. Now, what if they come in and they can only open to 25 or 20? Then we start with 20 or 22. And they add one or two every week with a vibrator on the muscles. And so I give them a vibrator. We've got them in the office, and it just helping get rid of the lactic acid.
There's one right there.
Yeah, here it is right here. And they just put that on the muscles and vibrate it while the tongue depressors are in their mouth. And I'm telling you, I've been doing this like this for 25 or 30 years, and once I discovered this technique, if there's anybody I haven't gotten over their myofascial pain or TMJ problem, I'm unaware of it. I'm telling you, it works. So see, she's got this in the mouth, and then she's vibrating. I say, where's the pain? This is the spot. We're getting rid of that lactic acid. Muscle relaxant, sometimes I'll give them, usually I give them a 10 milligram Valium they can take at bedtime, or sometimes I'll give them a Flexeril, a 5 milligram that they can take 3 times a day. Now, I also do trigger point injections. That's into the point of pain to get rid of the lactic acid in the muscle and relax it so they can stretch the muscle if it's a myofascial. Sometimes you'll inject into the retrodiscal tissue. Now I use Sitness 4% plain with no vasoconstrictor because it doesn't last a long time. And if you injected up here, you could anesthetize the superior nerve that goes to the eyelid, and they can't close their eye. In that case, be sure they bring their sunglasses with them. It rarely happens, but if it does, it's not a big deal. You could put something over their eye when they go outside, because without vasoconstrictor, this is only going to last about 15 minutes. But sometimes when you inject up here, you could anesthetize the superior branch of the nerve that goes to the eyelid. So what I do is I spray ethyl chloride on the face. I first have them put their finger on the dot, alcohol it, but after they put their finger on the dot, I put a little alcohol it, put a little black dot there with a pen, and then inject the Sitnest 4% plain. And I'll usually inject about half a carpule. Chiropractic treatment is great if you've got neck pain. I'm a big believer in chiropractic. My wife and I both had some neck and back issues through the years, and neither one of us have any right now. So if you can find a good chiropractor and they've got neck pain, if you can palpate right here and they've got neck pain, shoulder pain, back pain, it all kind of connects, and that's a big help. So that's that. Trigeminal neuralgia, you can read about this. What time is it now?
It's 10:15.
10:15, okay. So I'm not going to go through that a lot. You can read this. This is going to be posted in our dentistrymasterclasses.com, right?
Yes, sir.
But knowing what to do with these, the bottom line is, if they've got, this is what I've had luck with. If they take carbamazepine, is a newer derivative of oxycarbazepine, and this many times will control it. You don't see that many, but I've had patients with this, and that controls a lot of them. If not, they can have gamma knife surgery, which just sears or whatever it does to the nerve, whichever branch it is, and I've had patients get over it with that. This is the office I refer to in Austin, but I don't see them very often. This is what her pain was like, and it's like electric pain. There's no other pain like it. It just sets them free. What? Tic-tac-toe-root, trigeminal neuralgia. So these are the treatments for that gamma knife. This is the first line right here. I have a patient, been a long-term patient, he just developed it, and this is working well on him. You can do the Gilletta procedure, put a Teflon pad between the artery and the trigeminal nerve. So this is a patient, I'm going to let you watch her video. So when she came in, she could barely open 30 millimeter. We've stretched her to this. At the end of the first appointment, by the end, she could open 50. How did you feel when you came in here? Why did you come here to start with? What got you in our office?
I had gone to several different specialists and dentists.
In what? In TMJ?
In TMJ.
TMJ specialist.
General, yeah, just like other dentists as well. And everyone had different, like, remedies, if you will, for different night guards and
So did you have some treatment at those places?
But treatment, they just gave me like a night guard to do. And then over time, it just never really helped and worked. And I never really got better.
How long have you been doing that?
Oh, for years.
For years?
Yeah.
When did this start?
Probably my sophomore year of high school. So like
And you're now
6
a
years.
what?
Graduating senior in college.
Graduating senior from college, okay.
But for most of the time, I didn't do anything about it. I was just trying
Just
to
live
push
with it.
through. I was trying to be tough.
And what were your symptoms?
I kind of experienced a whole variety. Started with just discomfort, and then I would get locked jaw, to where I wouldn't be able to open super wide. And then
Closed, but you couldn't open.
correct. After that, I had to get a crown on my back molars, and
This was done in Dallas.
Yes, it was at a new dentist that I never gone to before. Just a referral. They just didn't like shave it down well, I guess. And so then my bite was super uneven. That got really bad. I was grinding my teeth so hard at night that it cracked my tooth. So then it got to a point where everything was just really painful. Jaw was painful, like
Facial pain.
tooth pain, facial pain, mostly on the left side, where like the crown was that I had a bunch of work done. One, I didn't have like a big bite, so it was really hard to eat. And then
Started to bite
every
down?
time, yes, every time I had to eat or do anything, speak for a long time, sing, I love to sing, and I couldn't sing because I couldn't open my mouth. And so then it just got super painful, and I was having really bad nerve pain. And so that was whenever we decided to come here. It was nerve-wracking to like try something else, and I really don't like dental, like I don't like everything in my mouth because the past however many years have been so painful and just hard, but it's been awesome.
So we evened your bite, gave you an occlusal orthotic appliance, I did trigger point injections, then gave you the tongue depressors to open your bite. Now you can open the 48 with no problem. So are you having any pain now? Nothing?
No,
Can you open wide, chew, everything,
Yeah.
sing? Fabulous.
Yeah.
Well, that's what we expect with this treatment.
And back to perfect condition.
All right.
Yeah.
Great. Thank you for interviewing.
Yeah, I'm super grateful.
Okay, so what's the takeaway? This is not one particular patient. I've got bunches of interviews of patients, from opera singers to on down the line. It works. It has to work if you just understand the concept, which is even the bite, having bone on bone is not a problem, or bone on retrodiscal tissue is not a problem. That may be a little uncomfortable in the beginning because remember the nerves are in the retrodiscal tissue. So you want to even the bite, and you don't want the second molar, the distal of the first molar, or the four anterior teeth to be contacting. You want them out of occlusion when the patient squeezes hard. That's the only time it counts, when they squeeze hard. You want an occlusal orthotic appliance that they wear only when they're sleeping. What teeth contact on the occlusal orthotic appliance?
No back teeth,
No back teeth, only the
molars.
cuspid teeth.
Because they can handle it.
Yeah, because they're the big boys in the front. They got the big roots. This is so much more fun than just me talking. So only the cuspids, because what happens to the muscles when only anterior teeth are contacting?
The back ones relax. They relax.
90% of the muscle fibers shut down and don't contract because the dainty little incisor teeth are biting. They say, oh, this is the ballerina. We don't need to grind, whereas the posterior teeth are grinding. Then everybody needs to get their hand on the rope. All the muscle fibers need to grind. Thank you, Guy Haddix, for that. Okay, so get the occlusion right. No contact, second molars, distal of first molars, four anterior teeth. Be sure they're not in occlusion, not way out, but just a little bit. Then they'll super-erupt back into contact over several months, but you know it's not a premature contact. The only way you can know it's not a premature contact is if you take them a little bit out of occlusion. I usually take them out of occlusion on articulating paper thickness when they squeeze. Just I can pull it through gently. It just touches a little bit, but I can pull it through. Four anterior teeth, Second molar is distal of first molar. Then you give them the tongue depressors. The beauty of that is, when I figured that out, I said, I need something that we can change. And so you start with the thickness of these that they can open. So you may take this many out, say that's 30, and they start with this. Say this is 30, and they start with that between the front teeth, and they put this bad boy on the muscles and vibrate with these between the teeth. And they may take one of their 10 milligram Valium before they go to bed or before they start doing this. And then every week, as they can open, you know, they may drink a glass of wine or something like that before they do it, just kind of relax the muscles. They add these, and the thing that's so important too is they've got a goal. That's what I tell them. I say, I've never had a patient, except for this one elderly woman that was about 85, that couldn't get to at least 40. And they look at these and they say, really? I said, really, you'll do this. But add 1 or 2 a week. If you just add 1 a week, is that okay? I'm going to be practicing for a long time. It'll just take longer to get to the end. So add 1 a week until you get to the point you can open, you know, go back to that last. Do I have that last one on her opening? Oh, I got to do it, don't I?
I mean, I can do it. You talking about the video?
This. So see, she could only open about 30 here, and this is 50. And they all get to that point. I'm telling you, this is the way to treat TMJ and myofascial pain. All right, so trigger point injections, if you want to do that. I've done it so long, it's no big deal to me. But I spray the face with ethyl chloride. Be sure you cover the eye and the ear auditory meatus. You don't want to spray it in there. I don't know what you certainly don't want to spray it on the eye. And deaden it, numb it, and then use a 30 gauge needle with Sitness plain, which doesn't have any vasoconstrictor. So what we're trying to do is loosen up the sore spot so they can open either the retrodiscal tissue or the master muscle, so they can open as wide as they can in the office. So then you give them an occlusal orthotic appliance that only contacts on the anterior teeth. I'll sometimes give them a 10 milligram Valium prescription that they take at night before they go to sleep, or a 5 milligram Flexeril, which they could take 3 times a day if they want to. So the first appointment, I see them for a couple of hours and do the equilibration, the occlusal orthotic appliances, the trigger point injections, and those other things that are listed. Then I'll see them again in a week or 2 the first time and just check the occlusion. Because the occlusion will kind of settle in. Remember, centric relation is not an area, it's a dot. It's a dot. Centric relation won't change. But as the teeth have been equilibrated, they'll move microscopically to a position of stability. So you may have to do a little adjustment on the teeth to keep them in centric relation occlusion. And after a time or 2, they'll be in a position of stability, and the occlusion won't keep shifting just a little bit. But you'll usually have just a little adjustment as those teeth shift. Not centric relation. It doesn't shift. It's the same every time. It's a dot. And I'm not going to go into how I can tell you that, but it is a dot. But you'll do a little adjusting here, and then you'll check their progress with these with these splints. And the patient really gets into it because they know what the goal is. And they say, okay, I got in 10 between the last appointment and this one, because we've got an end goal. We're not trying to get 80 millimeters. We're just going for 40, because they can eat anything. The dog can run all around the yard. You don't need a leash that's 100 feet long. You just need one that's long enough that it can chase a cat anywhere in the yard. So that's it. And remember, any kind of disc repositioning surgery does not work. I can say that from personal experience. There's nothing to stitch it to that will hold. The disc stitched to the retrodiscal tissue will not hold. It'll tear loose. Stitched, doesn't it make sense? Stitched to a screw in the distal of the condylar head, that won't hold. Removing the disc completely, you could do that, just go in and surgically do a discectomy, but it's hard to get through to the disc on the mesial, the inner part of the condylar head, because it's such a tight little space. And it's a big surgery, and you've got bleeding, and you just open up a can of worms. What we're trying to do is stretch that retrodiscal tissue, tear it, whatever you want to call it. Don't we have a video in dentistry master classes of these patients being interviewed, like Deborah and different ones, talking about what?
We have individuals.
Okay. So we're going to keep putting these things together, because TMJ and myofascial pain is certainly not all I do. I see restorative cases from all over the United States that have either need a lot of restoration. We do a lot of all on fours, because many of the patients we see have waited too long, and it's like a house damaged in a hurricane. You could probably save them, but it'd be such a big job. It's more practical to take the teeth out and put in all on four. I don't do plain dentures just because I don't want to deal with, I'm not good at it. I don't want to deal with trying to make something fit that I can't make fit and be stable. But the videos on Dentistry Master Classes, you'll see if you're subscribed, it's like $39 a month, and we've got, yeah,
So this complete webinar this morning in its entirety will be posted on Dentistry Master Classes later today. We'll go ahead and share a link to that now in the comments. Also, there are a lot of procedures that Dr. Cupworth mentioned today: evening the bite, trigger point injections, how to manipulate into centric relation, how to make a Nygaard, a splint. All of those
fundamentals of occlusion, yeah.
Right. All of those have extensive videos in the TMJ section of dentistrymasterclasses.com. We'll also share a link in the description. If you subscribe there, it's 99 cents for the first month, then $40, $39 a month after that.
Now remember, we're not making any money off this. This is $39 a month. You're helping us keep this going if you like this type of thing. And I've got videos on it.
Preserve the work.
Yeah, that's right. My mentor's work is not really preserved because they didn't have video back then. And so this is to preserve these techniques and hopefully help you in the way that people helped me when I was starting out. So this is just, I mean, we've got techniques on everything from implants to apicoectomies to frenectomies to full mouth reconstruction, increasing vertical dimension, comprehensive cases. But those are only in dentistrymasterclasses.com. They're not just in the Dental Minute. So anyway, what else?
Are there any questions that he needs to answer?
Why are there no dental books talking about this? And I put the link.
What did you say? Why are there no dental books talking about this? Good question. Good question. Every time I see this stuff walking in my office, I go, what the hell? What is going on out there?
Well, you
Nobody.
talked with the person at Baylor who used to help teach it.
Yeah, Chuck Arcoria asked me to set up my teaching center in Dallas. And I think it's just, I don't know.
Somebody else is saying you need to write a book about everything you know.
If you guys would pay, dentists to me are wonderful people, but you got to have a little help with this because we're coming out of our pocket to do this just to give back like my people did to me. So the thing you can do to help all these things happen is pay $39 a month and subscribe to dentistrymasterclasses.com, right? Anything I'm leaving out? Yeah, everybody wants it, but it's like for 20 years I took groups of dentists, 12 dentists down to Mexico to learn hands-on implants. But a lot of dentists just, they want something for free. It's not for free. You know, it's just, I can teach you how to do almost anything, but you got to have a little help. So anybody else got a question or comment?
That was about it. That was about it.
That's about it.
Yeah, if you could just say the outro, the Dentistry Master Classes, the Dental Minute.
See what?
Your outro, the
Okay.
Outro.
So that's dentistrymasterclasses.com. These techniques work, and they work every time.
and then the Dental Minute ones.
That's the Dental Minute. These techniques work, and they work every time. Glad y'all were with us today.